I'm here to speak to you on a very interesting topic, CTEPH after discharge, pulmonary thromboendarterectomy and a case for balloon pulmonary angioplasty. I come from Narayana Institute of Cardiac Sciences in Bangalore, and we are among the 10 largest centers in the world which deals with pulmonary embolism. So fasten your seatbelts for a very exciting, the management on how CTEPH is managed at our center. I have nothing to disclose. So multimodality management of CTEPH, we are following the San Diego classification, which is level 1, 2, 3 and 4. So for the level 1 and level 2, we have the surgeon who does the CTEPH surgery, that is pulmonary thromboendarterectomy, and for the level 3 and level 4, it's us, the interventional cardiologist, who does balloon pulmonary angioplasty. And of course, there's medical management, which is particularly for the microvasculopathy in the distal pulmonary artery tree and for all levels of pulmonary embolism at its chronic phase. So this is a snapshot of how pulmonary embolism is managed. First of all, the cornerstone, of course, is lifelong anticoagulation. The treatment assessment is by a multidisciplinary team in which we have the cardiologist, the radiologist, as well as the pulmonologist and the surgeon who participate in decision making. So if the patient is operable, of course, yes, class 1 indication is to offer pulmonary endarterectomy surgery, and if the patient is inoperable for various reasons, then we offer either balloon pulmonary angioplasty or medical management as the case may be. Remember that lifelong anticoagulation is required both pre-procedure as well as post-procedure. By procedure, I mean both surgery as well as balloon pulmonary angioplasty. This is the 2022 ESC ERS guidelines regarding the management. I have abridged it to suit this particular discussion. A class 1 indication is pulmonary endarterectomy surgery, which is recommended as a treatment of choice for CTEPH patients with fibrotic obstructions within the pulmonary arteries which are accessible by surgery, which means that level 1 and level 2, your endarterectomy forceps is able to reach the clot. Balloon pulmonary angioplasty is recommended for patients who are technically inoperable, which means that the surgical team has seen and opined that they cannot be operated for various reasons, which I'll just allude to in just a minute. And of course, those who have residual pH after a surgery, that is endarterectomy surgery, has been completed, and distal obstructions which are not amenable to surgery, wherein the forceps does not reach the distal pulmonary artery tree. All of these are class 1 level of evidence B indications. And that medical management, class 2A level of evidence B, even before balloon pulmonary angioplasty has been done. Now, let's look into pulmonary thromboendarterectomy surgery. The disclaimer here is that I'm not a surgeon, I'm the cardiologist, but we work closely. So, this is the decision that our team takes as far as management is concerned. The steps of pulmonary thromboendarterectomy is that there are 4 cornerstone or basic principles. The approach is through median sternotomy because you have to expose the lungs adequately, and it's almost always bilateral. Perfect visualization is absolutely essential, so the patient has to be on a cardiopulmonary bypass. These surgeries extend almost 8 to 10 hours, sometimes even 12 hours. This is a long surgery, and there are periods of circulatory arrest which are limited to just 20 minutes, and you'll have to cool and warm the patient several times. We bring it down, the cooling, to about 20 degrees centigrade and then rewarm the patient. Otherwise, the patient can have irreversible brain damage as well. Identification of the correct plane, that is the endarterectomy plane, is the most important. Now, what is this endarterectomy plane? It is between the outer and the inner tunica media layers. So, this is the plane at which the surgeon has to get in to dissect out the clots. And of course, the surgery has to be bilateral. So, these are the 4 steps in surgical pulmonary endarterectomy. This is a snapshot of how to approach the right pulmonary artery, the left pulmonary artery, and of course, how exactly to dissect into the endarterectomy plane. This is a snapshot above left on the instruments that are used. Most important here is the instruments that are required to reach that endarterectomy plane, and of course, the forceps to pick out the clots. Now, this is a short video to show how exactly pulmonary endarterectomy is done. This is my chairman, Dr. Devi Shetty, and Dr. Julius, who are doing this surgery. So, this is pulmonary artery being opened, suction catheter used, and this is the forceps which is actually scooping out clots. You can see that clots are being extracted out. they come in just like a candle mold. When you pull it out, the entire pulmonary artery tree, the clot fills in that, and when it comes out, it comes out like a tree with its branches. Next up is balloon pulmonary angioplasty, which I do as one of the members of the CTEPH team. So the indications for balloon pulmonary angioplasty is, first of all, the patient has inoperable CTEPH. Why inoperable? If the patient has advanced age, comorbidities, surgically inaccessible or very distal or peripheral lesions, residual lesions after surgery, and of course recurrent CTEPH after surgery has been completed. All of these form indications for balloon pulmonary angioplasty. We use the SCAR algorithm, which is basically a suspicion raised by echo or a VQ scan, confirmed with a right heart cath. We do a pulmonary angiogram or a CT pulmonary angio or an MR angiogram, as the case may be. We assess the risk of the patient by assessing the hemodynamics, comorbidities, and of course the surgical team's experience. So this is a snapshot of what are all the investigations that you should do: echo, right heart cath, VQ scan, CT pulmonary angio, routine biochemistry. We are a center of excellence, so most centers refer to us. Abdominal ultrasound to look at portal hypertension, pulmonary function tests, chest CT for pulmonary hypertension, and of course a digital subtraction angiogram. This is the 2022 EHC guidelines regarding the recommendations for the same. I'll just run you through what are all the investigations we do at our center. This is a standard 4C 4-chamber echocardiogram showing a torrential tricuspid regurgitation. We also do 3D echo, and this is called as a grid mapping. The entire right ventricle is broken down into small grids, and with this we can assess the fractional contraction of the right ventricle, or the summation of this is the total right ventricular function. Why is it so important? Because the right ventricular function is the one that determines the survival of the patient as well as your success after the procedure. This is again the TAPC, the TAPC followed by the speckle tracking echo. This helps us to differentiate the pressure versus the volume overload. It is far more accurate than TAPC and also the S prime, and very, very sensitive to say that. So this is the way the speckle tracking echo is done. We do it as standard protocol for all the patients. Next up is the 3D assessment. We have a fantastic echo team led by Dr. Satish Govind, and this is, he renders a 3D image of all the patients, and we have a 3D comprehensive assessment. We have the various software at our disposal which will help us to assess the right ventricle. On the left top, we also have a latest addition, that is the hologram. So with this, you can actually get into the right ventricle and see the various chambers, the moderator band, what are the clots, and so on. So this adds to our expertise and our assessment of the patient. Right ventricular clot assessment, Dr. Justin already showed you, and Dr. Raghu, this is with reference to you. So if you have an anatomy like this and you're pushing in your catheter, if you dislodge one of these big clots, there's likely to have the patient likely to have an arrest on table. This is very common in acute on chronic pulmonary embolism. VQ scan, we do a ventilation and a perfusion scan, and then the last image shows a spin image wherein we spin it in multiple directions to see the perfusion. This is to decide how severe the disease is. We have a CT pulmonary angio, again a spin CT is what you're seeing here. This again helps you to assess the in 3 dimension how significant the disease is. And of course, this is the image which our radiologist gives us, and you have a spin image. The usefulness of this is for me to approach the distal segment in the bronchopulmonary tree to access lesions for balloon pulmonary angioplasty. We also have a new equipment, that is the dual energy CT. So not only you're doing a CT of the lung, you can see the areas of fibrosis, the pulmonary fibrosis, pulmonary infarction, and of course the perfusion. All of this combined in one shot, plus a rotational image. So you can spin it in multiple directions to see how severe the disease is. And the MR pulmonary angiogram, we use it as a reserve test, but the good thing is that again this has got a 3D spin facility and also a perfusion image. So if you have any doubt after a VQ scan, after a dual source CT, you still have an MR perfusion to fall back on to come to a conclusion regarding the need to do a procedure. Needless to say, a pulmonary cath and an angiogram is done in selected cases. We reserve the pulmonary angiogram only in selected cases where I need to do an intervention. It's not commonplace for all, because this carries its own risk, including an arrest on the table if the patient is unable to tolerate a load of contrast. So this is only in cases where an intervention is mandatory. The last thing is we have a 4D MRI. The good thing about this is you can use it to measure the turbulence in the right ventricular outflow tract. This will be a lot before the procedure, and it will definitely come down either after endarterectomy or after balloon pulmonary angioplasty. So all this is available at our hospital. You don't have to use all of them, but when these are available, this really eases your task in decision making as to which procedure is for which patient. Next, we look into how to do this balloon pulmonary angioplasty. This is a 3D spin of the bronchopulmonary segments. So we have to target 5 to 6 segments in one sitting. So I can assess based on this which are the segments to look at. We do a collateral angiogram because these patients can have torrential hemoptysis, and that can often be fatal. So we need to know where are the collaterals, especially in the middle of the night if the patient brings up huge amounts of hemoptysis. Unless you go and coil it or select PVA particle or inject PVA particles, the patient is not going to make it. So having an idea of these kind of collaterals adds a lot of value in your intervention. Risk stratification. The first thing when I do a procedure is the patient relatives ask me what is the risk. If you see in the red zone, these are the patients wherein the 6-minute walk test, the CAT studies, the echo, the cardiac MRI and hemodynamics are all unfavorable. They carry almost a 20 to at times 50% mortality on table. Better to be upfront about it and take a high risk consent before embarking on these procedures. Now lesion classification, this is a type A localized ring procedure, localized ring lesion. Type B is a web kind of a lesion. Type B, subtype 1 is a longitudinal defect that you can see. So as we move ahead, it gets more and more difficult to tackle these. Complex mesh is even more difficult to tackle. And of course, you move on to the abrupt narrowing. The problem with this is a mismatch between the proximal and the distal vessel size. And subtotal occlusion, from here on, it gets even tougher. And as a center gains experience, only then you should venture into these lesions because there's a chance of a rupture of these arteries. And a pouch lesion wherein you don't even see the track, and a tortuous lesion wherein the chance of a bleed when you're doing an intervention is very high. So lesions C, D and E, stay away from them at least in the beginning part of your program. Apart from this, as a center of excellence, we have IVUS, we have OCT and we have angioscopy. So the middle picture is fascinating because in the OCT, it looks like you're sitting on the probe and actually getting through the pulmonary artery. You can see the overhanging bits of the webs, the clots, and what exactly you're dealing with and what kind of treatment you're offering to your patient. The procedure as such, right femoral vein access, O14 guide wire, graded balloon dilatations, dynamic alterations, and 5 to 6 branches in one sitting. No more than that, otherwise you're likely to produce a reperfusion edema. Strategy, look for the easier lesions like webs or bands. Stay away from subtotal occlusions, chronic total occlusion, and tortuous lesions at least in the initial part of the program. What you're doing is you're rupturing the web, and then neointima forms, and the whole pulmonary artery is once again reformed. And the results vary because even though you're doing a balloon pulmonary angioplasty for all the patients, the pathology that is inside is different. There are 4 different types of pathology. So according to this, it will be the success of your procedure and how efficacious your treatment has been. Hardware, this is what we use: a long sheath guide wires, which is called the BPALM or atraumatic wire, crossbander balloon, which is atraumatic, and the balloons of various sizes, and gelatin sponge particles wherein there can be a bleed. When do you stop? Once you reach angiographic size, IVUS or OCT is helpful, or the distal to proximal ratio is more than 0.8. There should be a cutoff time per institute: 60 minutes fluoroscopy time, 300 ml contrast, or 2000 mgy of X-ray exposure. With that, you stop. I'll rush through in the next 30 seconds the various cases that we did. This is the very first case that I did: right upper lobe, right upper lobe pulmonary artery, very tight narrowing, balloon dilated, and this is a successful procedure. This is a middle lobe total occlusion. I got into this fairly early. I used a Fielder XT wire, exchanged it with a soft atraumatic whisper wire, and then balloon dilated, and the entire middle lobe opened up. Then this is again a patient from Kenya who came in with oxygen. We opened up the middle pulmonary lobe artery. You can see this, and then completely the patient recovered and could go back without oxygen support. I'll take just 30 seconds more. This is left lower lobe total occlusion, case 4. This is a software engineer. We opened the left lower lobe. You can see that balloon dilated, and the panel in the lower left shows the entire lower lobe pulmonary artery opened up. This patient had a perfect oxygen saturation. In fact, he's participating in the competitive sports now. This is another patient who had a very tight stenosis in the left lower lobe, 2 such cases, case 5 and case 6. You can see that after balloon dilatation, the flow is excellent with a 0 gradient across this particular stenosis. This case 8, this is a total occlusion. Here again, we opened it up with a graded balloon dilatation, and you can see left lower lobe completely opened up. This is a software engineer from Hyderabad. Her services were terminated because of frequent taking medical leave, and we opened the total occlusion here. You can see that her saturations greatly improved. Now she has started her own company, and she has 105 employees under her. So this is the difference that a procedure like this can make. This is a case that I did day before yesterday. Patient came in with CTEPH, crashed, and like Dr. Vijay and Dr. Justin had said, patient was on ECMO. So the way to bail out was, there were 3 total occlusions. I opened 1 middle lobe occlusion, I opened 1 lower lobe occlusion, and 1 upper lobe. You can see all the 3. Panel 1 is the middle lobe, panel 2 is the lower lobe, and panel 3 is the upper lobe. Patient is off ECMO, doing fine, and we are planning an elective CTEPH surgery in the days to come. How do you assess success? We have a 3D fusion spin image, and we also have OCT. So with this, we are able to assess the success. We also use 4D MRI in such patients. Lastly, we do combo procedures. That is, we combine with the surgeon. Sometimes they are able to do level 1 and level 2 by themselves, and we follow up to do level 3 and level 4 in the hybrid lab. So there's really no need to transfer the patient to the cath lab and achieve success. Complications, bleeding is the biggest complication. You can see here this particular case. This is a young lady, just 23, 24 years old, and there is really nothing that you can do if you have a bleed like this. So fortunately for me, I got away by doing a balloon tagging for about 15-20 minutes, and the bleeding completely stopped. Otherwise, you'll have to call in the surgeon, and they have to ligate it or inject gelatin sponge particles to stop the bleed. Other interventional procedures, septostomy, IVC filter, we've discussed this. We've also done a few cases of PA denervation, as you can see in the lower panel. And the last case, the last one that we did is one that separates the boys from the men. We did a percutaneous spot shunt for a patient who had severe PAH. Excellent result, and the patient is now totally independent and off oxygen. Collateral embolization, I already highlighted to you. The panel above shows coil embolization for a torrential bleed, as you can see there. And the panel below, we injected PVA particles and shut it down before the patient could succumb. Thank you everybody for your attention.